So, good evening, everyone, and welcome to our webinar. So, those kind of webinars are organized by the Emergency Department of University Hospital of Casablanca. So, my name is Mohammed Mohawi, as most of you know, and I will be your moderator today. So, thank you for taking the time to join us. We are very excited to have such an engaged audience from you, maybe more from Casablanca and Morocco and maybe around the world. So today's session is about talking about Syncope, History is Queen, and we have an exceptional speaker with us, and I think I'm confident. I'm confident you will find the insights shared today valuable and thought-provoking. So once again, it's my pleasure to introduce you our distinguished speaker, Professor David Kerr. So Professor David Kerr is a professor of emergency department, and he is working in the University of Toronto in Canada. We are truly fortunate to have him with us today to share his expertise on this field and with his exceptional lecture. So maybe you don't know this, but Professor David Carr was dedicated 3 times in a row as the best speaker at the USEM conference. So when I say USEM conference, it's about the European Society of Emergency Medicine Conference, and it's just amazing. Before we begin, I'd like to remind everyone to stay engaged and feel free to ask questions using mainly the chat. We will address them during the discussion segment at the end of the presentation. So, David, without further ado, I'll hand it over and the floor is yours.
Amazing. Thank you for the kind introduction. I'm just going to pull up this talk. And before, Mohammed, maybe you can just tell me when you have everything in full screen view and it looks good to go.
It's okay. It's
Okay,
okay. Full screen. Okay.
amazing. Okay, so it's a great honor. Mohammed has been a good friend and someone who's I've gotten to know after recently visiting Morocco this summer for a special birthday. And it's a great honor to have the option to speak to you. And I understand it's 8 at night, and some of you have put your kids to bed, some of you had a long day of work. And what I want to do is make this fun. We're going to talk for about 30 minutes, and then we're going to have a lot of time for questions. And the questions can be about syncope, or the questions can be about whatever you want. Okay, about training systems, whatever. And we'll kind of keep questions to the end, and Mohammed can monitor the chat to see what are the pressing issues. Now, you go through emergency medicine having a topic, having something you love. There are things that I don't love and there are things that I love. I love syncope. You pick up a chart, it's syncope, I'm happy. I pick up a chart, it's epistaxis, I'm miserable. So this is my favorite topic. And what we know about syncope is it's got you will see this about 2% of your visits, and it happens about 48% in one's lifetime. So syncope is going to happen to me or you. And the question is, can I give you a framework to be ready for it? Now, what this test is not about is it's not about high sensitivity troponins or biomarkers. And I'm even going to try to tell you that I'm going to try to devalue the EKG. There are a handful of EKGs that you need to memorize and know about when you see someone who has fainted, but we're going to talk about something else. Now, I should probably give you some conflicts of interest to tell you who I am. So Mohammed said I'm an emergency doctor from Canada. My interest is esoteric, bedside, old school emergency medicine. Now, I'll be honest with you. I routinely lie about fundoscopy. I sometimes make up JVP. And during COVID, I barely examined people. But what I have my gift, and I believe everyone has a strength, is my strength is I can take a history. And with syncope, that's what you are going to need to do. You're going to need to know is how does it feel? And what the end of this 30 minutes, what I'm going to hope to convince you is that history is queen, is that history is absolutely everything. So we know that 15% syncope cardiac for 30% in elderly, and about 15% of these non-cardiac conditions can present. But this is Casablanca. This is Morocco. I mean, if someone comes in who's short of breath and hypoxic and they syncopize, yeah, you're going to think about a PE. And if someone's pregnant and has abdominal pain and syncopizes, you're going to think about an aortic dissection. Or sorry, an ectopic pregnancy. We're going to focus not on this. We're not going to focus on non-cardiac causes of syncope. We're going to talk about cardiac syncope and give you a framework to how to think about it and how to diagnose it. Now, one of the first and most important pearls that I want to put out there, and it's a study that was in Annals about 5 years ago or so in 2018. It looked at syncope and near syncope in the elderly, and it looked at 3,600 people. It looked at 1,400 people who almost fainted and 2,200 elderly people who fainted. And then it compared the two groups for 1 month and looked at major adverse cardiac events. And what they found is that if you almost faint, near syncope, or you faint, syncope, the outcomes are the same. So what I want you to think is if some elderly person or anyone comes in and they almost faint, I want you to realize that pathophysiologically, you drop your cerebral perfusion pressure and you almost faint or you faint, the differential diagnosis is the same and the prognosis is the same. So just because someone made it to a chair and was able to sit down, that doesn't mean it's benign. Pearl number one, syncope equals near syncope. Okay, probably the second most important pearl I want to tell you in this talk is when I was in my training, I used to think that cardiac syncope was you had some chest pains, some palpitations, and then you fainted. Now, that's actually not what cardiac syncope is. Cardiac syncope is you're feeling totally fine, and then boom, you just drop. And that might mean you fall forward. And if you break your glasses, meaning you didn't have a warning, you didn't have time to protect yourself, that's a pretty good red flag. Cardiac syncope does not have pre-syncope. It does not have warning. So when you're teasing out the history, the most important thing is to get from the patient, what did you feel before you fainted? I was getting my blood work done in the clinic at Casablanca. I started to feel very hot and sweaty. I was starting to feel very nervous. I thought I was going to faint. And the next thing I remember is someone's putting some ice on my head. Well, that's not cardiac syncope. That had a definite pre-syncope, and that's not the way cardiac syncope is. I'll never forget, I had a patient who came to see me once about 5 years ago, and she started the interaction by saying, "Doctor, I'm so sorry to be wasting your time." And I don't know what it's like in Morocco, but I can tell you in Canada, usually bad things happen to nice people. I knew when she was apologizing something was going to be bad because that's just the way it is in emergency medicine. And she said to me, "Doctor, again, I'm so sorry for wasting your time. I probably should be at a dentist." I said, "Okay, well, what's going on?" She said, she was young. She was like 25. She was a teacher. She said, "Doc, every day I get up at the same time. I have a shower. I'm really low maintenance. My shower lasts about 3 or 4 minutes. And then I get ready and I go off to school to teach." Well, today, went to the shower, felt totally fine. And the next thing I know, it's like 8:20 and I wake up in the shower face down and I've chipped both my teeth. "I'm so sorry for being here. I probably should be at the dentist." Okay, I get the dentist issue, but tell me what happened before you fainted. "Oh, I don't know. I felt totally fine. It was a normal day. The pressure, the temperature, it was all the same." The next thing I knew, I was on the ground. Okay, well, I didn't like her story. And remember, this talk is about history being queen. So I referred her to an inpatient service, figuring it was a Friday and they could expedite maybe an echo, put her on telemetry, get some tests. I called the team and they said, "Well, do you have a troponin?" I said, "Okay, well, we do have a troponin because the nurse drew it, but it's not really relevant." The troponin was undetectable. So the resident said to me, "Do you have two troponins?" I said, "Look, I can do 1,000 troponins. They're not going to change. This isn't about troponin." So they come see this patient begrudgingly. After about 10 minutes, they send her home to arrange some outpatient appointments. And I get a call from one of our cardiologists. And Carolyn says to me, "You remember that patient you saw who fainted?" And I'm sure it's the same in French and Arabic. When someone starts that conversation with, "Do you remember that patient you saw?" It's very sphincter tightening. I was all nervous. And she said, "You sent this teacher to me who fainted in the shower." I said, "Yeah, yeah, I remember her." She said, "I did a Holter for 72 hours. I did an echo. It showed nothing. But David, I agreed with you. There was something in the story was off. So I did an implantable loop recorder for 7 days. And she ended up fainting and she ended up having a run of torsades. And she said, "You know what the most amazing thing is? She has an identical twin. And I did a loop on her, and she also was having runs of torsades." History saves lives. Her ECG was normal, her troponin was normal, but the story was evident. Cardiac syncope has no warning, and it should always make you afraid, especially if they chip their glasses or their teeth. Anyone know who this person is? Well, I'm not here to tell you much about history, but this is Phidippides. Phidippides was the fastest runner in Greece. And the Greeks were in a war with the Persians, and he was in a city called Marathon. He was able to see that the Persians were advancing, and Phidippides ran 26.2 miles from Marathon to Athens, kilometers. And he got there. He told the emperor that the Persians were invading, and then boom, he went down. The first incident described of sudden cardiac death in sports. Now, the key here is that this incredible athlete who self sacrificed his life, but exertional syncope should also make you nervous. Someone who's getting their heart rate up on the treadmill, on the Peloton, on the bike, going out for a run or a jog, who faints should always make you nervous. Just like cardiac syncope lacks warning, especially when it's exertional, you should be afraid as well. Now, one of the things that always comes up in the ambulance reports or bystander reports is I wasn't sure if he fainted or if he had a seizure. What we know is about 90% of patients who syncopize will have myoclonic jerks. If you ever watch videos, and this is morbid, but I have a lot of athletes that I really love, and I've watched their videos where they've had cardiac arrest, they'll all shake a few beats. So, can we put this together? A few things we know is people who have epilepsy and they have a seizure disorder, yeah, they're probably more likely to have seized. People who have a postictal state are typically more likely to have seized. Tongue biting, that always gets asked. Tongue biting's common, but if you seize, your tongue actually protrudes out your tongue laterally. You bite the lateral aspect of your tongue. So tongue biting, which is lateral, is 96% specific for a seizure. You can imagine if you fall forward and chip your teeth, you might have central tongue biting, but lateral tongue biting is a clue. Now, people will talk about prodrome or incontinence. It can happen with both. I remember a patient I had, and he was a 50-year-old guy, also a teacher. And his story was similar. I woke up in my bed and don't know what the hell happened. I was covered in pee. I kind of freaked out, but realized I had to go to school. So I go to school, I start teaching, and the next thing I know, I'm covered in pee. So he had been incontinence. I was thinking, did he have a seizure? It was never described. His ECG was normal. I did like a confusogram. I ordered every test I could think about. I scanned his head, and he was completely normal. And he said to me, "Doctor, I just want to go home." And again, maybe a North American thing, but the number one reason why people go home poorly and stupidly in Canada is they want to go feed their cat. Now, for some reason, I don't know why people really love cats and they don't need to be fed every few hours. But this guy went home to feed his cat. And I begged him, I said, "You know what? Usually I don't care when people leave. Please don't leave." And as I was talking to him, he had a sinus pause of about 25 seconds. And this was cardiac syncope with no warning and just incontinence. Now, it turned out, which he didn't tell me, he was using whopping doses of erectile dysfunction medications like um, uh, Cialis or Viagra. I can't remember what their generic names. He had just overdosed on them, but he had poisoned his heart. He did have incontinence, but he had no warnings. But I think probably the best way to differentiate syncope and seizure is what I like to call the 10 to 20 rule. And this is a fantastic tool that you can use with bystanders or EMS or paramedics to ask them, was this syncope or a seizure? Let me make this really simple. If you have less than 10 jerks, syncope. If you have greater than 20, seizure. So, people always flip out when they're bystanders. Just ask them, how many jolts did he have? Was it like three or four, or was it going on? It was like 20, 30, 40, 50. That is a great tool for you when you don't witness it to know, is it syncope or seizure? Because remember, 90% of people who syncopize will have some myoclonic jerks. Now, I don't know what you do, but I've always been taught to ask about family history of sudden cardiac death. I'm looking for Marfanoid people left, right, and center. And I'm looking for family histories of cardiac death. And I've asked these questions for 21 years of practice. And only in 1 year, one time, did a syncopal person actually say to me, this is what happened. And I have a family history of sudden cardiac death. Well, this is a little different. What I want you to do is I want you to broaden your questions. Instead of just asking about family history of sudden cardiac death, I want you to ask two more questions. Has anyone in your family drowned for no good reason? Or has anyone in your family had a single unprovoked collision for no reason? Now, when someone drowns, to me, either you're drunk or you don't know how to swim. But if someone drowns in your family for no reason, you can only assume that it is cardiac. It is likely exertional cardiac syncope in water, which is not a good place to be if you faint. And that's a missed opportunity. So expand your family history of sudden cardiac death and ask about drowning and unprovoked single vehicle collisions. What about paramedics? The paramedics possess the holy grail. They often will see people and they'll do funny things in their presence. I remember a long time ago, about 6 or 7 years ago, my grandmother, who was in her early 90s at the time, she was brushing her teeth and all of a sudden she felt very dizzy and lightheaded. The caregiver looking after her, called the paramedics and they got to her place and her heart rate was 30. They rushed her by ambulance to the nearest hospital. Now, I was hoping to get her to my hospital, but they didn't feel she could wait. They get to the hospital and I get to see my grandmother. And sure enough, everything was great. The emerge doc said to me, he was one of my old residents, Dave, blood work's normal, EKG's normal, vital signs normal, troponin's normal. And I said, okay, but I heard her heart rate was 30. Oh, no, it's been fine here. Well, do you have the strip from the paramedics? Where are the paramedics? So sure enough, we went to find the paramedics and she had a run of complete heart block. And instead of just saying she's normal, by doing that extra bit of digging and looking at the rhythm strip, she got herself a pacemaker. She ended up living a long time because it's hard to deal with pacemakers, hard to die. Now, I'll tell you about the rhythm strips. It's funny, when you give a talk, you often run into interesting scenarios related to the talk. And I was prepping for this talk this summer. I had a patient who came in, and the chief complaint was severe chest pain, non-STEMI, high risk EKG changes, elderly female. And the story came through, and the paramedic said to me, yeah, we're really worried. We brought her to your hospital because you have a cath lab and we lost her for a little bit, but she's doing okay now. We gave her some aspirin. I said, whoa, whoa, whoa. What do you mean you lost her? Well, she went unconscious for a bit. Was she on the monitor? Yeah. Do you have a rhythm strip? No. Can we look at your monitor? Yeah. So we went and looked at the monitor, and sure enough, she had a run of VTAC, pulseless. This N-STEMI didn't need just aspirin and ticagrelor and heparin. She actually needed a cath lab because she was a very unstable person. Always look at the rhythm strip. The rhythm strip is the holy grail of cardiology. Make sure if you capture it, and when I see patients who have a run of AFib, and it's in the pre-hospital setting, sometimes I'll take the patient's phone, take a picture of that rhythm and say, just so if you ever this gets lost because it wasn't done in the hospital, you can show this to your internist, your neurologist, your family doctor that you had a run of atrial fibrillation. This is your proof that you will likely need to be anticoagulated. Now, what I will say about pacemakers is pacemakers are inserted because people's hearts have failed, because they no longer work. Your heart sucks. Stop diagnosing vasovagal syncope in patients with pacemakers. I will say that again. If someone has a pacemaker, the cause of their syncope is likely not vasovagal. Now, this might mean that you have to get their pacemaker interrogated, and that can be a pain in the butt. But patients with pacemakers who faint need an interrogation to figure out what's actually going on with their device. Now, as I told you during COVID, I barely examine people. And for some of the new people who are super keen on ultrasound, a stethoscope is kind of like an ultrasound for your ears. What I will tell you is if someone faints and you're not auscultating for that murmur of aortic stenosis or valvular heart disease, you are not, you are signing your soul to the devil. What I would say is you have to remember how important is auscultation is in the patients who syncopizes. The number of people I've seen who fainted where I've diagnosed their pansystolic murmur up their carotids with brachioradial delay, it's not rare. Elderly people syncopize, and you need to have a listen. You need to go old school. What about their physical exams? Pretty easy. Have a listen. What about blood work? You know, you don't really need blood work. We all do it. I mean, if someone tells me that they've had their period for 65 days and it's been bleeding a lot, yeah, I'm sure that cause is going to be pretty apparent when their hemoglobin's 62 or something like that. But for the most part, you don't make brilliant diagnosis of syncope in clear-cut stories by blood tests. You make it by history. And one of the other things I think is really important is you have to realize, and I don't know the rules in Morocco, but if someone has a seizure or someone has cardiac syncope, someone has to ask, are they fit to drive? In Canada, if someone has presumed cardiac syncope, we notify our Ministry of Transportation to do a fitness to drive assessment. I encourage you to do the same thing. I know it can be painful for people, especially who rely on driving as a modes of employment, but I'd much rather them drive safely knowing they've been worked up than be in a truck on the highway and kill a handful of people. So, people talk about decision rules. I don't know if you use decision rules. There's a Canadian syncope score, there's a San Francisco syncope score. I'm Canadian. I'm not North African, but I'm not anything for these decision rules. The San Francisco syncope, if you use it, is too straightforward and too obvious. And the Canadian one is too cumbersome, which needs a lot more validation. And both of those don't need any blood work. You got to just use your old school bedside gestalt and figure it out. Take a history. Now, we got to change gears. Now, whoever was the marketing manager at McDonald's, I don't know how you got to keep your job when you're advocating for a diet of Big Macs and French fries and Coca-Cola, where the rhythm strip shows some erratic P wave and a run of non-sustained VTAC. I don't think I'm loving that if I'm the marketing manager, but we're going to let that slip. And we're going to let that slip, and we're going to talk a little bit about EKGs. But this is Morocco, and what we're not going to do is really, yes, if someone comes in and their heart rate's 34 and then they're not a 28-year-old marathon runner, you can pretty much guess that they've got some heart block or their cause of the syncope is something about cardiac output. We're not going to talk about that. We're going to talk about 5 or 6 key EKGs that I think you need to consider in every single person with syncope. Now, may have heard of the wobbler mnemonic, or you just can listen to this talk, and all you have to do is memorize 5 different EKG patterns. And if you look for them on every patient with syncope, you've gone a long way. Because if someone hands you an EKG with obvious cardiac syncope, and I'm not talking heart block, it's gravy. It's a gift, and you have to celebrate. Now, these are two of my favorite basketball players growing up. And, both of these guys, Hank Gathers and Reggie Lewis, died on basketball courts. And both of these guys had fainted in the weeks prior to their death. Now, when you watch Hank Gathers was supposed to be like the next Michael Jordan. He had fainted and was cleared to play. Then if you watch the Hank Gathers video, you will see that he dunks the ball, he comes back on defense, he looks completely normal, and then boom, he drops to the ground. There was no pre-syncope. You can see it in his eyes, and he has about 3 myoclonic jerks, and he's dead. And the sad thing is, if Gathers presented to your emergency department in Casablanca or Fez or Marrakesh or Iswaria, wherever you're watching from, would you make the diagnosis? So this is what would have been Gathers' ECG. And the first thing you're going to look at it and say, oh, he's a young guy. I mean, he's got LVH. That's kind of strange. Oh, maybe he had an old MI. He's got some Q waves in the inferior leads. Well, the first thing I want to say is that LVH, when you see that voltages, LVH is a chronic problem. We don't really care about that as emerge docs, but you only get LVH with an inciting event. So you can get LVH, but you have to assume that that person has chronic hypertension, or maybe in the elderly or a young person, some congenital aortic stenosis or aortic stenosis that's not congenital that you can auscultate, but you don't get LVH overnight. That is key. LVH tells you something's wrong with this guy. The other thing you should realize is this an old inferior lateral MI? The Q waves that he has in 2, 3 AVF and the high lateral leads V5 and V6, they're not pathological. Pathological Q waves are 3 blocks as wide. These are very narrow. These are like dagger-like Q waves. And when you see dagger Q waves in the inferior and high lateral leads, with LVH without an inciting stimulus, you have to think about the most inheritable cause of sudden cardiac death in athletes, and this is called hypertrophic cardiomyopathy. We used to call it HOCM, or hypertrophic obstructive cardiomyopathy, but 75% of people with hypertrophic cardiomyopathy don't have left ventricular outflow obstruction. This is a key thing. You might diagnose this by the auscultation, but when you see LVH without a stimulus, when you see sharp and dagger-like Q waves, think about HCM. But the history is everything. What about this couple? This couple was visiting Toronto from Germany. They were on a tandem bike. They were riding, and in the distance, they saw an ice cream truck. So they each pedaled really, really fast. And the woman got off the bike. She was 26 years old. And the next thing that happens is boom. She exerted herself and then had sudden cardiac demise and syncopized. Now, fortunately, she came to. But I don't even have to show you the ECG, do I? You don't like her story. Exertional syncope without warning. So I don't know in Morocco when you do EKGs if they tell you the box, if they tell you up front what the computer interpretation is. But usually we discourage people from reading it. But what I don't discourage is for people to read the rate, the PR interval, the QRS interval, the QT, because those are pretty well calculated. When you see this woman and it will say short PR, then you scratch your head and you go hunting for delta waves of WPW. And when you look here in lead 2 or in lead 1, you could see or an AVL, a very obtuse delta wave. And what the delta wave is when you look at the upstroke from the isoelectric baseline to the R wave, it takes a long time to get up that mountain. And that's why in lead one or two or AVL, it's quite blunted or obtuse. That's going to be your delta wave. And that's what you're going to be your clue that this person has WPW and probably had a run of antidromic conduction and fainted and will need to have look for this, what's going on, and maybe have a defibrillator. The key is you have to recognize that two delta wave is short PR. But the story is everything. Let me tell you another story. This 32-year-old guy had a cough and cold, and this was long before COVID, so it wasn't on my radar. He gets referred to me as a STEMI, and I'm looking at this guy. He's in the minor area. I guess he went to his family doctor. He felt a little dizzy, had some palpitations. He got an EKG, and the EKG said STEMI positive. So I was like, this guy doesn't look like a STEMI. He looks like a guy with a bad cold. So I asked them to do another ECG. They put my name on it, and the nurse says, Dr. Carr, it looks like it's another acute MI. I looked at this ECG and I said, I've been waiting for you for a very long time. Does anyone know what this is? This is Brugada. And what do we know about Brugada? Is Brugada causes ST elevation in lead V1 or V2 that is downward sloping. What we know about Brugada is that it's 20 times more likely to show up as an arrhythmogenic phenomenon in patients who are febrile. So often we see people with febrile illnesses and palpitations, and with COVID, it kind of changed things, but maybe we thought it was the cough and cold medications. But if you're going to see Brugada, they're 20 times more likely to present when they're febrile. And when they're afebrile, they might not give you that type 1 Brugada pattern. In the setting of dizziness, syncope, pre-syncope, making this diagnosis saves lives. Let me tell you a really scary statistic. If you see this ECG, you do some blood work, maybe you do two troponins. The guy's healthy, his tropes are normal, he feels better, he's got a fever, you give him some paracetamol, you say, it's probably bronchitis, you smoke, don't worry about it. There is a 10% chance that he's dead in 365 days. The mortality of missed Brugada is 10% per year. Don't miss Brugada. Okay. One other amazing ECG. Now, this woman was a paramedic and she was rock climbing. Now, I'm sure people like to rock climb where you're from. You have beautiful deserts and great mountain cliffs to do this. And she was doing this inside in Canada. And she was going up to the top. And it's one of these things where you get to the top and you ring the bell. And she exerted herself. She got to the top. And the next thing she knew, she went down. Her partner, he was also a paramedic. He brought her down to the ground. He said she was unconscious for about 20 seconds. She didn't have more than 20 jolts, maybe a few jerks. He said her heart rate seemed fast. And then she came to. And she comes to the emergency department and she hands you a gift. Now, you might not know what this is, and you might only see this once in your career. But now we've planted the seed. When you look at this ECG, you're going to say, she's got some diffuse T-wave inversions in her precordial leads, V1, V2, V3, V4. Is this a Welland syndrome? Well, it doesn't sound like it. This is not a chest pain, not an ischemic story. She's got some other weird things. When I look at her QRS complex, they look kind of weird, especially in V1, V2, V3. Looks kind of strange. Well, what I want to tell you, do you know what she has? She has something called arrhythmogenic right ventricular cardiomyopathy, or ARVC. It used to be called ARVD. Now, one of the things you'll see in ARVC is two things I want to tell you. One, they often will have a T-wave inversion in V3. And then when you look at the isoelectric baseline and you look, it's kind of like a delta wave, but the reverse. So they go up, no problem, unlike a WPW patient. They go down, no problem. But from the nadir of the S wave to the isoelectric baseline is an obtuse, blunted thing, like you see here in lead V2 or V3. And buried in that is a little blip. And that blip is called an epsilon wave. But the key is up, down, up. They can't get back up the mountain. That's ARVC. You just got to look for it. That's a gift. But you know what? She had exertional syncope without warning. Did you even need the EKG? I just got to put this out there because do you guys ever see old people who fall and hit their head? Yeah, of course you do. And all of these people are all on some fancy AFib medication like rivaroxaban or apixaban. So what happens? They all come in, they hit their head, they get a CT of their head, sometimes a CT of their spine, they get blood work and EKG, and they go home. Well, this woman had been in our emerge 4 times in a year, and every time it was the same thing. Blood work, EKG, CT, our geriatric emergency nurse specialist. Let's increase supports at home. Let's give her a walker. Let's give her a support on the toilet. Well, at every single time, her ECG looked the exact same. And when I saw this, I said, she keeps fainting. We don't need to keep CT in her head, or maybe we do. We have to ask ourselves, why does she faint? When I look at her ECG, the first thing up top, it will say bifascicular block. Now, in the old days, we used to say this is a bifascicular block with the first degree AV block. We used to call this a trifascicular block. The cardiologists don't really like that term anymore, and they want to call it a bifascicular block with a first degree AV block. Remember the following. You have 3 fascicles. If 2 of them are blocked and you keep fainting, that's not a coincidence. If you have syncope plus a bifascicular block, or if you have syncope plus a bifascicular with a first degree block, that person needs telemetry and someone to consider, someone meaning a cardiologist, whether given that person's story, they would benefit from a pacemaker. Now, I'm not talking everyone with a bifascicular block needs a pacemaker, but certainly the ones who come to your department 4 times a year with fainting episodes, I bet you they do. And I bet you when they did her telemetry or they did her Holter, they saw that she was having episodes of 3rd degree complete heart block, and that's why she was fainting. This is a great slide for those of you who want to take a picture of the screen. This is kind of how I organize it. I always say that history is queen, that history is everything, that the ECGs are just a gift, a gravy, but you need to get comfortable to have an approach. For every single person I see on a patient with syncope, I write no HCM, no WPW, no ARVC, no Brugada, and no long QT. And I look for those 5 things. And if you do that, you're not going to miss any of the electrocardiographic evidence of syncope. But the story is something that is just written on the chart for you to read. Let me give you one bonus case just because I think this is fun and we have a little bit of time left. I saw this patient and she was odd. She was a yoga instructor. Now, I don't do any yoga and I don't know anything about yoga. But she said to me, doctor, every time I do downward dog, and rather every time I do upward dog, I faint. Okay. Now, some of you might think that that's a language en français or in Arabic that you know what the hell she's talking about. I had no idea what the hell she meant. So I said to her, can you show me what's an upward dog? So she gets on the floor of our emergency department and does a position like this, and she syncopizes. And I kind of freak out and I said, okay, whatever you're doing, we're never going to do that again. And I kind of think about it. And I said, okay, well, this is weird. Why does she keep fainting every time she extends her neck? Has she have a dissection? So I say, you know what? This is weird. I'm going to do a CT scan of her neck to look for a carotid or vertebral dissection because she's been fainting or getting pre-syncopal. And I get a call from the radiologist. And, sometimes you get a call from the radiologist and you know what's coming because you have one CT and you know the patient's interesting. So he calls me and he says, Dave, she has classic eagle syndrome. I said, she has classic what? Don't you just hate it when radiologists try to outsmart you? I said, what the hell's eagle syndrome? He said, well, she has an elongated stylohyaloid ligament that is pushing against her carotid. So probably every time she extends her neck, that calcified ligament pushes on her carotid and causes her to faint. Kind of like the old people who used to faint when they shaved and pushed on their carotid. This was wild. And we published this case report, and this person ended up getting surgery. But the key was, yeah, this wasn't cardiac syncope, but it was weird syncope. You got to take a history. If the history's weird, go fishing, go looking. So, how do I wrap up? A couple things I'll say. After spending some time in Fez and seeing the ambulance system there and seeing that there's not great roadways in this authentic, beautiful Moroccan city, and being in the desert and in the mountains in Morocco, if you live really far from a hospital and you have elderly parents, I think defibrillators are like the fire extinguishers of the 21st century. If you can afford it and your parents live in the middle of nowhere, get them a defibrillator for their holidays. That will save lives. What else can I tell you in conclusion before I wrap up? I can't say this enough. History is queen. Establish pre-syncope. Understand what cardiac syncope is. You go down without warning. Understand that near syncope equals syncope. That exertional syncope should make you nervous. That you don't need a real workup. You need an EKG, maybe a beta HCG, maybe a CBC. You certainly don't need troponins for run-of-the-mill syncope. But your EKG, when you get it, look for those 5 things. They're gifts. And if you get those, you're saving young people's lives. And that's what we do. And that's what really matters. So I just wanted to thank you for your time. I hope you guys learned something. And I'm going to stop sharing my screen. And I hope we have some questions that I'm happy to take.
Thank you so much, David. It was something we have learned a lot of things, a lot of insights, a lot of reflections, so a lot of big messages regarding syncope in the emergency department. And if I well understood, you have focused your lecture about cardiac syncope, and maybe we can ask some question about no cardiologic syncope. Maybe we'll have a lot of questions on the chat. So thank you very much, David. And we'll give the floor to the chat if you have any question regarding this lecture. Regarding the lecture or anything regarding emergency department. So let's do it. So you have
I can see I see the chat now I'm monitoring. What are the unique challenges evaluating syncope in the elderly? There are lots. Often it's multifactorial, and often, it's much cleaner when a 30-year-old faints and you can take a great story. Obviously, someone has to be a very good history teller. But we know that the incidence of cardiac syncope, which is about 15% in all comers, goes up to 30% in patients who are elderly. So cardiac syncope is really the can't miss diagnosis in these people. And it's either going to be arrhythmogenic or it's going to be obstructive. And what I would say the most important thing is you got to get comfortable with auscultation. It's something that's a dying art. Some of my junior doctors, they don't even have a stethoscope around their neck. And I'm just like, where's your stethoscope, dude? You need that. Come on. And they don't want to listen to people's hearts. So I think that in elderly people, sometimes the histories aren't clear, but you really got to look for aortic stenosis. And you really just got to hound them down as to what were you doing? There's a lot more orthostatic hypotension. So certainly with elderly people, especially if they're diabetic or Parkinson's, I will say to them, was this postural? Did you stand up and this happened? Was it a change from positioning? Because orthostasis fits in much more than in your 26-year-old athlete who faints.
Okay, you have another question regarding pediatric patients? So if
I'm
you are
just going to
able
read that.
to, yeah,
So I don't pretend to be a pediatric cardiologist or anything like that. I think pediatric EKGs make me a little bit nervous, especially when they're like 4 years old or 6 years old. Um, I think that again, they're in certain ages, and in different ages, you have to realize when are the incidents of going to be congenital heart disease. I think if it's a recurring pattern that's not vagal, and I think so much of syncope is vagal, and often taking a family history, like mom, dad, you're in the room. Do you guys faint when you get blood work done? Do you faint when you're having a big bowel movement? Do you faint when you're getting a vaccination? I think excessive vagal tone runs in families. My sense is you need to auscultate and probably arrange follow up for recurrent cardiac syncope in kids. But I mean, it depends what age we're talking about. And obviously, a 4-year-old is different than a 1-year old. That's different than a 12-year-old. That's different than a 17-year-old who weighs 100 kilos. So I would say that you still are going to have take histories, but obviously that varies based on age, and pathology in really young pediatric people can be much more likely to be real.
yeah, of course. So let's do it for the third question. How does syncope during exercise differ from other contexts?
Well, I just think it's a higher risk thing because it's almost like a failed stress test, right? You increase your cardiac output and your heart can't tolerate it. You're not generating enough output, and that's why you drop your cerebral. You don't have enough blood flow and you faint. So the other thing we know, and it's unfortunate, like we have a major marathon in our city. I know some of the most famous runners of the world are Moroccan, or and we have these big marathons, and every year someone dies. And it's like these are the fittest people in the world. They're not lazy people like me. They're people who run, 100 kilometers a week, maybe 200. And why does one of them die? Well, unfortunately, we're more likely to have arrhythmias as our rate goes higher. And I think, therefore, cardiac syncope is a much more real possibility in someone who exercises. And it always makes me nervous. It's kind of like if you get chest pain when you exercise, it's a real red flag.
Yeah. So let's move to the next question about Brugada syndrome. So
Yeah,
does
duration of syncope, how long? I don't know if that influences outcome. I think that, obviously in the context of Brugada, like this person who I saw didn't even faint, they just felt dizzy. But you know that if you're evaluating them, I don't know how many of you seen like someone come in with a wacky tacky of Brugada who comes in with an antidromic deduction and you have to cardiovert them and they're 23 years old. I mean, obviously those people are legit, but the key here is that if you pick that up, you're saving people's lives. And that's something you have to realize about. Sorry, I mixed up WPW and Brigada, but I think the key here is that however long isn't the real thing. And I don't know in terms of screening in the general population because I think we screen based on family histories. And obviously, if there's an ethnic disposition, for example, ARVC is very prevalent in the Greek Isle of Naxos. So, yes, maybe if you're a Naxonian person, they get screened. But I think for everyone else, and I'm not a cardiologist, I think you have to ask a really good history. And it's not just sudden cardiac death, it's expanded to drowning and to someone who just crashes their car for no reason and dies. And, and like, there's no reason. I had a guy who was riding his bike and he was like a professional cyclist and he fell off his bike. And, when I asked him, like, oh, you fell off your bike? And he said to me, I've fallen off my bike many times, but when you fall off your bike, you're like, oh crap, I'm falling off my bike. I'm going to brace for fall. Um, he said, I have no idea what happened. I was riding my bike up a hill, exertional, and the next thing I know I'm in your hospital. I didn't fall off my bike. I just dropped off my bike. And then when you get the story from paramedics and the people who saw him on scene, he didn't hit a pothole. He didn't hit a curb. He just moved over. And so I think it's still all about in exertional syncope, whatever the rhythm is still taking that story.
okay? So David, the next question.
Yeah, they're happening quick.
Uh,
Yeah. Oh, so this issue about cardiac syncope and syncope, like all the cases, like when I told you the case about the teacher who broke her teeth, when I told you about the teacher who wet himself and kept passing out, had completely normal EKGs. So I think the differentiate between cardiac syncope and non-cardiac syncope, it's amazing when the ECG gives you that. But when it doesn't give you that, it's your history. And I think the excellent doctor saves a life by diagnosing people not on a blood test, not on an ECG, but on a story. And that's being old fashioned. It's listening to people. So for me, cardiac syncope doesn't need an ECG. It needs a very concerning story. And then it needs to have someone else work that person up, whether that's your internal medicine person, your cardiologist, whether that means at an outpatient clinic, whether that means in your emergency department. That's a systems issue. But that person's going to need Holters and echoes and an electrophysiologic study like a sodium a procainamide challenge test if you're worried about a channelopathy. But that comes out of our hands. It's your job to make the diagnosis that you're worried about cardiac syncope. It's easy when you recognize it on EKG.
David, I think you missed a question just before this one about when should we screen for Brugada syndrome in general population?
Yeah, I don't have a clue. I actually don't know. I don't think. I think like if someone has a fever and they're having palpitations, I'd be more likely to do an ECG. But as a general population approach in Canada, we don't screen EKGs for people looking for cardiac syncope who are asymptomatic. I think I would certainly do it on someone who told me, you know what, my brother just drowned. I think I want to get checked out. Well, that's going to be an echo and a Holter and an ECG. But in general populations at large without family history, I don't know that answer. It's kind of above my role as an emergency physician.
David, I think you have a question about people who are experiencing syncope with with orthostatic hypotension.
Yeah, I'm going to go to that one. Look, I mean, you can do postural vitals. I think a lot of people like postural vitals. I think that you have to recognize that some drugs cause orthostasis, that diabetes and Parkinson's are going to be the two conditions that should trigger. But again, orthostatic syncope and orthostatic hypotension should be very positional. It should be I got up from the toilet, I got up from the bed, I stood up too quickly, and I felt like I was going to faint. It's a very situal thing which will have pre-syncope. And that pre-syncope will be very positional and postural. And I think if you can establish, like in your elderly Parkinson patient, well, there's some medications to treat them, like midranone and other things, to help deal with their causes. So I think it's what makes you feel like you're going to faint. We know that near syncope equals syncope. Let's just say, are there factors that you have pre-syncope that's orthostatic sounding? And then sure enough, you can do orthostatic vitals in the emergency department, get them to sit, to stand, to lie, and there's your answer.
Yeah. I think the next question is about the impact of stress and or anxiety for triggering cardiac syncope.
Yeah, I'm sure there's some role. I don't think it's a major role.
Yeah.
I think that chalking that up to stress would be a diagnosis of exclusion. I think you have to rule out sinister stuff. I mean, certainly palpitations and certainly people can feel dizzy. But if someone's fainting, let someone else tell them it's anxious. Don't make that diagnosis in the emergency department.
We have a question written in bold text about how do you approach the evaluation of syncope in patients who are on multiple medication?
Yeah, so often the people who look, hypotension and bradycardia make people faint. Cardiac output is heart rate times stroke volume. If someone just started a calcium channel blocker that is that's rate controlling or a beta blocker and they faint, well, that's going to be part of the problem. If someone's just new medications and their blood pressure is low, that's going to be part of the problem. I think you have to, that's where good primary care, maybe good internal medicine follow up to look at polypharmacy and drug interactions. But we all know we see people who come in and their heart rate's 35 and they feel like crap. And what happens? The inpatient team stops their beta blocker, stops their calcium channel blocker, and either their heart rates get better or they get a pacemaker. These are often elderly people who are going to go down the battery of their heart's not working or those meds aren't working. And sometimes it's just trial and error.
Yeah. Are you able to see the next question about TTE, echocardiography?
Yeah, I mean, I would say that TTE, or at least what I do is a bedside point of care ultrasound. I don't have the skill set to look for valvular heart disease. I rely on auscultation for that. But certainly, if you think of non-cardiac causes of syncope, such as ectopic pregnancy, aortic dissection, pulmonary embolism, those are things that have sonographic findings that you might determine with point of care ultrasound. But it's not my practice in a young, healthy person who has a syncopal event to do a ultrasound looking at them just because I don't have the skill set. Now, that doesn't mean that they don't need it. It just means they need someone really smart to do it, and I'm not that person.
I think the next question is very interesting. Are there some tips to make differentiate between syncope and transient stroke?
Okay, so remember, like a TIA, I assume that's what we're talking about here. Like, loss of consciousness is not from a TIA. A loss of consciousness needs global bihemispheric dysfunction, where neurovascular events are unilateral. And one of the best things I ever was taught in determining between is this a stroke or stroke or neurovascular event, TIA or stroke or something else, is that the symptoms just happen like this, kind of like cardiac syncope. Like if you have whole body right-sided numbness, that sounds like a TIA. But if you had a headache and then 20 minutes later, a little bit of numbness here, and then 15 minutes later, a little numbness here, and then 30 minutes later, a little numbness on your right leg, that's a marching of symptoms, which is not neurovascular. Neurovascular events, much like cardiovascular events, are the occlusion of an artery or a rhythm disturbances that makes you have no warning and things just happen. So I would say to differentiate, syncope is not a focal neurological deficit. It's a sign of poor cerebral perfusion pressure, where neurovascular events are more territorial and they will have a unilateral picture, be it weakness or speech or numbness. But obviously, that mimic of seizure versus syncope, which we talked about, the 10-20 rule, is the only area where I feel that people mix up is seizure or syncope, and that's where those overlaps occur.
The next question will be about digital health. Because this guy is asking you about recent advances in machine learning and artificial intelligence.
Yeah, it's cool. I think it's the future. I mean, like, do you guys, Mohammed, you have the printout on top of your ECG that says
Yeah,
normal ECG?
yeah.
And how much, when you teach your residents, do you tell them to rely on it or?
No, no, we discourage them.
Yeah.
Every time I tell them not at any time you don't have to read this because it's the worst thing to do is to read the interpretation before interpreting yourself.
So I tell them the same thing. When I was a trainee, I remember I had an attending who used to cover it up so I couldn't see it, and I used to hate it. I will say that, as I mentioned earlier, I do look for QT and QRS and PR there because that's easy and it's calculated. I think machine learning for ECGs will certainly improve. I know some of you may be familiar with the occlusive MI paradigm and the Queen of Hearts app. And there's some apps now that take pictures of ECGs and will tell you whether you should activate the cath lab or not. Is this an occlusive myocardial infarction? I think we're not just going STEMI, non-STEMI. We're doing occlusive versus non-occlusive MI. And I think that, until we get to the point where you can screen an ECG, and it will give you all those answers. You memorize these 5 that I told you. But what AI will not do is take a history. And it will not take a history as well as you can. And that you just sometimes have to just ask yourself, like, do you believe the story? Can you actually get someone to tell you what you need to hear? And is it reassuring? And sometimes you just can't hear it well enough and it's worrisome and you refer them onwards. But I don't think we're replaceable yet. I think radiologists are, but I don't think we are yet.
Maybe we will take the 2 last questions before conclusion. So short question, short answer. Are there specific
Yeah, specific symptoms with palpitations. Yeah, sure. Any cause, anyone who's tachycardic or has an irregular rhythm will feel palpitations. The thing about palpitations, as we've all seen, is sometimes you see elderly people who are ticking at 170 and they have no idea that their heart's racing. So everyone feels palpitations differently. So I would say palpitations should make you look at the ECG like they're look at your syncope EKGs. Should we consider mental illness, substance abuse? I mean, substance abuse for sure if someone's abusing medications that are cardiac toxic, like amphetamines, cocaine, opioids. I mean, I think mental health is interesting because there's a lot of drugs that are, a lot of the psych drugs are really dangerous with ECGs, all the TCAs, um, a lot of the mood stabilizing drugs. They can screw around with your QT and stuff like that. And so I think it's mental health, it's more the medications that they're on is more the association.
Maybe the last one, really the
Should
very
the
last.
epsilon one and the bicycle back without look, I think if you see an epsilon wave in someone who syncopized, you should be nervous. I
Yeah.
think the history should prompt you to everything. I think sometimes we used to see bifasciculars and freak out, but if the story has nothing to do with ECG, then just let it's probably just an incidental finding. Tell the person they have a bifascicular block so they know next time they go to the emerge, no one freaks out about it. It's not new. But I think that again, good story, good EKG means someone else's problem. You need to refer that for someone else to figure this out.
So, David, before conclusion, if I ask you about if can you give us for young doctor from the audience something like 3 to 4 keywords, key messages.
Yeah, I would say the key messages are always be afraid of syncope without warning.
Mhm.
Always be afraid of exertional syncope. Always use the 10 to 20 rule to differentiate seizures from syncope because everyone has some myoclonic jerks. And memorize 5 EKG patterns and promise me when tomorrow you're working with Mohammed and you see a patient who's syncope or near syncope, because remember they're the same, you write on the chart no ARVC, no Brugada, no WPW, no long QT, and no HCM. And if you do that, you're a better doctor for listening to this talk.
Thank you very much, David. I'm so grateful for you. You were able to convince us and young doctor about the importance of history regarding syncope and the importance to be basic regarding management of patient, like something to really well interpret the EKG. So thank you very much, David. It was something like very interesting, very amazing. And if you don't mind, we will hope to see you again for the other webinar if you agree.
Sounds like a great idea in the new future, for sure. And hopefully one of these days, because you know I miss Casablanca, I'll
Yeah.
have to come visit you in person and see
Yeah.
your
Of course, you will be more
beautiful
than
country again.
welcome. So see you and thank you for you and for the all the audience and bye bye.
Okay, ciao, bye-bye, merci beaucoup.